Let's discuss the how to prevent the drowning in the children. So the drowning, they are the leading cause of the injury death for the young children age 1 to 14, and 3 children they die every day as a result of the drowning. In fact, the drowning they kills the more children 1 to 4 than anything else except the birth defects. The toddler years is equal to higher risk uh, than any other time. To lower the risk of the drowning and the other water-related injuries to the children, the American Academy of the Pediatrics they recommends the using the layers of the protection. When children they are not expected to be around the water non-swim times barriers they can help prevent the tragedies during the inevitable brief lapses in the supervision, which are normal part of every day. When children they are playing in and around the water, close and constant supervision they become essential. The fences and secure the swimming pools and remove or the fence other backyard water hazards and prevent your child from the going outside unnoticed. Empty layer water containers immediately after the use. Block unsupervised access to the bathrooms and provide the close constant supervisions in and around the water. Beware of the hazards at the homes. The most deadly accidents they affect young children happens in the backyard pools, but there are the very sneaky hazards around the house and the beach. That's why the being aware of the drowning dangers and the safety, the precaution is so important. Here, where to start? Bathtubs. Never leave a child under the floor alone in the tub or near a running bath. A school age child they can take bath by himself, but parents they should stay within earshot. The baby bath seats or the rings. Never leave your child unattended in the bath seat. He could slip down into the water and get trapped underneath. Or the rings they could tip over. The bucket and the containers. A curious toddler they can fall head first into the water-filled bucket and be unable to get out. Even a cooler filled with the melting ice they can be drowning hazards. Always make sure of the empty after the use. The toilet bowls. Keep the toilet cover down the bathroom door closed at all the times. Install a toilet cover safety latch. Now the fear of the drowning. This is the next topic, the fear of the drowning. How to reduce a fear or anything like the drowning. Interesting fact. The two-thirds of the American they are afraid of the deep open bodies of the water, and 46 they are afraid of the deep end of the pools. 37% of the Americans they are unable to swim, and almost 4,000 people a year in the United States they die of the drowning. The best way to get out over the phobia is especially it is very intense is through the counseling and the guided exposure. There are also additional sources that you may want to take advantage of, and will go over a few of them. Number one is the exposure therapy. Exposure work should take place with the directions of a therapist and should not be attempted without the prior consultation. Therapists they can work with a patient to create a plan for increased exposure as one can gain the successful experience. By exposure, one means to swimming, not drowning. Number second is the visualization. Using the visualization to overcome the fear of the drowning is a therapeutic technique of the imagining yourself in or near the water from a comfortable space. Visualization allows one to stay relaxed from an armchair as one conjure the image of the stepping into the water, splashing into your face and swimming and so on. When one approaches to the water, overcome the fear experience. Third is the self-education. A useful tool they can be self-education. It would be gauge of us to tell you there is nothing to fear because we understand that the phobias are more complex than that. However, the basic theoretical information about the aspects of the swimming such as the buoyancy or the breathing techniques they can help. Learning about the science of the life jackets, for example, that could help put your mind at rest if you have to go to on a boat. One day perhaps you can expose yourself to the knowledge of what it's like to drown. Reading this may be triggering, so please learn in a safe environment. Counseling. In the counseling, you will have an opportunity to talk about your fear and what led to it. The counselor will ask you many questions to help discover your reasoning. A common reason for a drowning phobia is an event in the past that caused you to fear the water. This could have been while the learning to swim or other times you spend in the water. The CBT, one way the therapist they may help you work through your fear is with the cognitive behavioral therapy. In the cognitive behavioral therapy, you will learn how to challenge the thoughts you have surrounding the drowning and how you can start to change them to affect you less. This might involve homework in assignments and the learning coping techniques and creating the positive message for yourself and will well and attending the weekly sessions with your counselor to talk through your fears. Counselors they cannot prescribe medication, so if your phobia is causing panic attacks or anxiety that could not be controlled with the coping techniques, a visit to a doctor they may be in order. Now the next topic is the differentials of the pain right hypochondrium. Liver disease is usually only painful if it stretches the capsule of the liver, as in the cognitive congestive heart failure. The liver they can be damaged by the blunt trauma. Hepatosplenomegaly can occur with the malignancy such as the lymphoma, chronic myeloid leukemia, or with the autoimmune disease including the primary biliary cirrhosis. The Bird Carey syndrome they can present in with the right upper condemned pain. The gallstones are common and become more common as the year advances. Most are the asymptomatic, but they can cause the pain at any time. Other gallbladder diseases includes the carcinoma of the gallbladder, which is always associated with the stone too. Ascending cholangitis has a specific classic triad of the pain, fever, and the jaundice and the duodenal ulcer. Now the next topic is the abdominal pain. What are the symptoms? Inquire first about the pain. Ask the patient to point out to where it is. Note whether the patient uses a single finger or the indicates the area is more diffuse. Ask the patient to what they were doing when the pain started. Note whether the onset is sudden or the gradual. Ask the patient to describe the nature of the pain, the stabbing, burning, gripping, continuous or the intermittent. Establish whether there is any radiation and ask whether there is any associated symptoms. And ask how long they have been had the pain, the time, and ask the patient whether there are the exacerbating or the relieving factors and establish how the severe the pain is rate out of 10. These points they can be remembered with the mnemonic which is known as the Socrates and note the past medical history, make a systematic inquiry. The patient they may volunteer information such as pyrexia, cough or the dysuria, discuss the appetite, any change in the weight, the bowels, the urine and the smoking and the drinking and the medication and prescribed and over the counter and the family and social history they may help. The signs. Note the general conditions of the patient, such as whether they are the fairly well shocked, paraxial, or the dyspneic. And note whether there is a jaundice. Note temperature, pulse rate, and the quality, and the blood pressure. And the patient they should be adequately disrobed, and both the patients and the examiner they should be in the comfortable position. A systematic examination of all the abdomen is required. Abdominal examination is described elsewhere. See the separate abdominal examination article or on the YouTube or anything else, or I will put a video for it. A full examination is required of the other bodily system, for example, examination of the respiratory system, and especially if the diagnosis is elusive. Now the next is the EPI schedule. The expanded program or the immunization was established in 1976 as a pilot project and has a port. In 1976, the pilot project with the 6 basic antigens, it is the BCG, measles, diphtheria, pertussis, and the tetanus and the polio. In 1978, it is expanded nationwide. In 1981, activities they intensified. 1994, the national polio immunization days were introduced, and 2002, the hepatitis B vaccine is introduced. 2009, pentavalent vaccine is introduced, and in 2015 the inactivated polio vaccine is introduced, and 2017 the rotavirus vaccine is introduced. In the pursuance of the 18th Constitution Amendment, the Ministry of the Health was abolished and the vertical programs including the EPI they was developed to the provinces. However, the Council of the Common Interest is in its meeting held on 28 April 2011 inter alia decided that the federal government will continue to finance these programs till the next national finance Commission and FCA board. Accordingly, the federal EPI cell continues to be financially supported through the federal PSDP regularly at the 2010 to 2011 levels. The resources it provides therein are primarily used to procure and supply the vaccines and syringes and safety boxes, and logistics needed to be provincial and the areas to vaccinate their target populations. Nevertheless, the provinces and the areas they through their respective EPI program units they are themselves responsible and they manage the operational cost of the immunization activities of the provincial and the district levels. EPI in Pakistan is coordinated at the national level. EPI Disal unit, the Ministry of the National Health Services and Regulation Coordination NHSRC, and the federal EPSL is headed by the national program manager, supported by a team of the technical and the administrative staff from the governments and developmental partners WHO and UNICEF. The API provincial Balochistan, Khyber Pakhtunkhwa, Punjab and Sindh and the areas Azad Jammu and Kashmir, Gilgit-Baltistan, FATA and CDA and ICT. They level they have provincial areas API cells they under the respective developments of the health and the managed by the provincial area API managers and the other staffs. The diseases, the cause of the infections, vaccines and the routine immunization schedules. So the vaccines includes the childhood TB, which is the cause of the infection is the bacteria. Vaccine is BCG. Dose is 1, which is administered soon after the birth. Next is the poliomyelitis, which is a virus, and it has both vaccines: oral poliovirus and inactivated poliovirus, and it has 5 doses in total. The one is soon after birth, then at 6, 10, and 14 weeks respectively. The rota diarrhea, or it is caused by the virus, which is vaccine is known as rota, and they are the 2 doses and at the 6 and 10 weeks. The pneumonia and the meningitis due to the streptococcus pneumoniae, it is a bacteria, and the vaccine name is the PCV10, which is the pneumococcal conjugate vaccine, has 3 doses at the 6, 10, and 14 weeks. Diphtheria is due to the bacteria, and the vaccine is known as the pentavalent. It has 3 doses, which are again at 6, 10, and 14 weeks. It also includes the tetanus, which is bacteria, pertussis, and hepatitis B virus. And the pentavalent vaccine is known as the DPT, Hep B, and the HIV vaccine. Again, the doses are at the 6, 10, and 14 weeks. The HIV pneumonia and the meningitis is because of the bacteria. It is included in the pentavalent vaccines. And the measles is due to the virus, and it causes the measles, and it has 2 doses at the 9 months and the 15 months of the age. This is the picture of the schedule which is given by the government. And now then moving to the next topic, which is the kwashiorkor was the marasmus. The kwashiorkor, it is a form of the severe protein malnutrition which is characterized by edema and an enlarged liver with the fatty acid infiltrate. It is thought to be caused by the sufficient calorie intake but with the insufficient protein consumption or the lack of the good quality protein, which distinguish it from the marasmus. The recent studies they have found that a lack of the antioxidant micronutrients such as the vitamin C, B carotene, lycopene, and the carotenoids, as well as the presence of the aflatoxins, they may play a role in the development of the disease. However, the exact cause of the kwashiorkor is still unknown, and inadequate food supply is correlated with the occurrence of the kwashiorkor. Occurrence is high in the occurrence in the high income countries are rare. It occurs amongst the weaning children to the age of the 5 years of the old. Jamaican pediatrician Cicely Williams, they introduced the term in 1935, 2 years after she published the disease first formed descriptions. The name is derived from the GA language of the coastal Ghana, translated as the sickness the baby gets when the new baby comes, or the disease of the deposed child, and reflecting the development of the condition in the older child who has been weaned from the breast where a younger sibling comes. And breast milk they contains the amino acids vital to the child growth in at-risk population. The kwashiorkor they may develop after the children are weaned from the breast milk and begin consuming a diet high in the carbohydrates, including the maize and the cassava or the rice. Welcome classification. The Wellcome classification is a system of classifying the protein energy malnutrition PEM, the protein energy malnutrition in the children based on the weight for their age and based to the presence of the edema. Other classification includes the Gomez classification and the Waterloo classification. The weight of the age and the with edema, without edema, and the general instruction considerations. The weight of the for the age 60 to 80%, if it is with edema, kwashiorkor, it is without edema, then the under nutrition. If it is less than 60%, then it is marasmic for sure, or the marasmus. If there is no edema, weight for the age is plus minus edema, reference standards 50 percentile marasmus. It is a form of the severe malnutrition characterized by the energy deficiency. It can occur in any one with the severe malnutrition, but usually occurs in the children. The body weight is reduced to the less than the 62% of the normal expected body weight of for the age. Marasmus, it occurs increasing the prior to the age 1, whereas the kwashiorkor, it occurs increased after the 18 months of the age. It can be distinguished from the kwashiorkor is that the kwashiorkor is a protein deficiency with the adequate energy intake, whereas the marasmus is inadequate energy intake in the all the form including the proteins. This clear cut separation of the marasmus and the kwashiorkor is however not always clinically evident, as the kwashiorkor is often seen in the context of the insufficient caloric intake, and the mixed clinical picture called the marasmic kwashiorkor are possible. Protein wasting in the kwashiorkor generally leads to the edema and the ascites, whereas the muscular wasting and the loss of the subcutaneous fats are the main clinical signs of the marasmus. The prognosis is better than is for the kwashiorkor, but half of the severely malnourished children die due to the unavailability of the adequate treatment. The word marasmus, they come from the Greek marasmos, which is the withering. The kwashiorkor and the marasmus causes the deficiency of the protein. In the marasmus, the deficiency of both the proteins and the calories, and the age is affected in the kwashiorkor between the age of the 6 months and the 3 years of the age, and in the marasmus it is between the 6 months to 1 year of the age. Edema is present in the kwashiorkor, whereas it is absent in the marasmus. And the subcutaneous fat is present in the kwashiorkor and it is absent in the marasmus. And the weight loss, there is some weight loss, however there is severe weight loss in the marasmus. The symptoms includes in the kwashiorkor includes the thinning of the muscles and the limbs. However, in the marasmus, it is a thinning of the limbs. The fatty liver cells, there is enlargement of the fatty liver cells in the kwashiorkor, and there is no enlargement in the fatty liver cells in the marasmus. Appetite is the voracious feeder in the kwashiorkor, and there is poor appetite in the marasmus. The texture of the skin is flaky, plain appearance of the skin in kwashiorkor, and it is dry and wrinkled in the case of the marasmus. The required of the nutrition is the adequate amount of the proteins, and in the marasmus it is the adequate amount of the protein, carbohydrate, and the fats. There are the 10 differences between the kwashiorkor and the marasmus includes. In the kwashiorkor, it develops in the age whose diet are deficient in the protein. It occurs in the children between the 6 months and the 3 years of the age, and it is subcutaneous fat is present, edema is present, enlarged fatty liver, and the ribs are not very prominent, and they are lethargic, and the muscle wasting the mild or the absence, and the poor appetite, and the person suffering from the kwashiorkor needs to adequate amount of the proteins. However, in the marasmus, it is due to the deficiency of the protein and the calories. It is common in the infant under the 1 year of the age, and subcutaneous fat is not preserved, and the edema is the present, and no fatty liver, and the ribs becomes very prominent, and their conscious state is the alter and the irritable, and the severe muscle wasting, and the voracious feeder. It is in turn the voracious feeder is here in the kwashiorkor, and the poor appetite in the marasmus. The person they suffering from the marasmus, they needs adequate amount of the protein, fats, and the carbohydrates. So moving to our next topic, which is the pregnant patient with the multiple sclerosis. It includes the management of the patient with the multiple sclerosis if she is in the active labor. The multiple sclerosis is a potential disabling disease of the brain and the spinal cord, the central nervous system. In the multiple sclerosis, the immune system detects the protective sheath, the myelin, that covers the nerve fibers and causes the communication problem between the brain and the rest of the body. Eventually, the disease they can cause the permanent damage or the deteriorations of the nerves, and there is no cure for the multiple sclerosis because it involves the deteriorations of the nerves. However, the treatment they can help spread recovery from the attacks, modify the course of the disease, and manage the symptoms. The symptoms often affect the movement, such as numbness or the weakness in one or the more limbs that typically occurs on one side of your body over time, or your legs and the trunk, and the electric shock, the sensation that occurs with the central certain neck movements, and especially the bending of the neck forward. The tremors, the lack of the coordinations or the unsteady gait, and the vision problems are also common, including the partial complete loss of the vision and using the one eye at the time, and often there with the pain during the eye movement, prolonged double vision and the blurry visions and the multiple sclerosis symptoms. It may also include the slurred speech, the fatigue, the dizziness, and the tingling of or the pain in the part of the body, and the problem with the sexual bowel and the bladder functions. The multiple sclerosis, they can make delivery more difficult. It may be difficult for a woman with the multiple sclerosis to tell when the labor begins, and there's an increased need of the forceps or the vacuum to assist with the delivery or the cesarean birth. Multiple sclerosis, it does not seem to affect the fertility, and the woman they able to become the pregnant. The medications that may be safe for the use by the pregnant woman with the multiple sclerosis includes the glyteramine acetate, which is the copaxones, or the generic the glatopa, or the interferon beta 1 a, it is the avonex, and the plidary or the rabib, and the interferon beta 1b, beta serons, or the corticosteroids, and the anesthesia used during the labor and the delivery. Now the next thing, it is the lecithin sphingomyelin ratio. It is also an important topic for the exam perspectives. Includes the lecithin sphingomyelin ratio. It is a test for the fetal amniotic fluid to be assessed for the fetal lung immaturity. Lungs, they require the surfactants are soap like the substance to lower the surface pressures of the alveoli and the lungs. This is especially important for the premature babies trying to expand their lungs after the birth. Surfactant is a mixture of the lipids, proteins, and the glycoproteins, lecithin and the sphingomyelin being two of them. Lecithin, they makes the surfactant mixture more effective. The lecithin sphingomyelin ratio is a marker of the fetal lung maturity, and the outward flow of the pulmonary secretions, they form the fetal lungs into the amniotic fluid maintains the level of the lecithin and the sphingomyelin equally until the 32-33 weeks gestation, where the lecithin concentration they begin to increase significantly, while the sphingomyelin they remains nearly the same. As such, it is a sample of the amniotic fluid has a higher ratio. It indicates that there is more surfactant in the lungs, and the baby will have less difficulty breathing at the birth. An LS ratio of the 2.4 or more indicates the fetal lungs maturity and the relatively low risk of the infant respiratory distress syndromes, and the LS ratio of the less than 1.5 is associated with the high risk of the infant respiratory distress syndrome. If the preterm delivery is necessary as evaluated by the biophysical profile or the other test, and the LS ratio is low, the mother they may need to receive the steroids such as the betamethasone to hasten the fetus surfactant and productions in the lungs. Procedure: amniotic fluid sample is collected by the amniocentesis, and the sample is spun down in the centrifuge at the 1000 rpm for the 3 to 5 minutes. Thin layer of the chromatography is performed on the supernatant, and which separates out the components. Lecithin and sphingomyelin are relatively easy to identify on the TLC, and the predictive values of the test are good. Now the next most important topic is the high blood pressure in the pregnancy. It is the gestational hypertension is diagnosed when the blood pressure readings are the higher than 140 by 90 millimeter of the mercury in the woman who had the normal blood pressure prior to the 20 weeks and had no proteinuria, excess protein in the urine. Preeclampsia happens when a woman who previously had the normal blood pressure suddenly develops a high blood pressure and the protein in her urine on other problems after the 20 week of the pregnancy. The women who have the chronic hypertension, they can also get the preeclampsia. Eclampsia, it is a severe form of the preeclampsia. Women with eclampsia will have the seizures resulting from the condition. Eclampsia, they occurs in about one in 1600 pregnancies and develops near the end of the pregnancy in more cases. In the rare case of preeclampsia, they can happen after one has given the birth. It is a serious medical condition as a postpartum preeclampsia. It can happen in the woman without any history of the preeclampsia during the pregnancy. The symptoms of the postpartum preeclampsia are similar to the symptoms of the preeclampsia. Postpartum preeclampsia is typically diagnosed with the 48 hours after the delivery, but can happen up to the 6 weeks later. The classic triad of the preeclampsia is the hypertension, proteinuria, and the edema. Today, edema is no longer considered an important part of the condition because it is a common finding in the normal pregnancy, and approximately one-third of the eclamptic women they do not develop the edema. In recent years, the new term atypical preeclampsia and eclampsia has been used to describe non-classic form of the hypertensive disorders arising during the pregnancy. Although there is no strict definition of atypical preeclampsia, it has come to include cases with the minimum or the no proteinuria. But the hypertension or the proteinuria with no or the marginally elevated blood pressure or without the hypertension or the proteinuria, presentations before the 20 weeks or more than 48 hours in the postpartum, those resistant to MGS or therapy, and the hemolytic anemia, elevated liver enzymes, and the low platelet HELP syndrome and its variants are also included in the atypical category. The pregnant woman with the high blood pressure higher than 140 to 90 millimeter of the mercury, if it is before 20 weeks, or either it will be after 20 weeks. If it is before 20 weeks, then see if there is a proteinuria. If there is no proteinuria or stable proteinuria, then it is corporate hypertension. But it is a new increased proteinuria or the HELP syndrome, then it is preeclampsia superimposed on the chronic hypertension. Then if it happens after the 20 weeks, see if there is a proteinuria, then it is preeclampsia. If there is no proteinuria, then it is the gestational hypertension. Now the management. The WHO organization, they recommends that the women with the severe hypertension during the pregnancy, they should receive the treatment with the antihypertensive agents. Severe hypertension is generally considered as systolic blood pressure of at least 160 or diastolic blood pressure of at least 110. Evidence they does not support the use of the one antihypertensive or over the other. The chronic, the choice of which agent to use, they should be based on the prescribing clinician experience with the particular agent, it is cost, its availability. And diuretics, they are not recommended for the prevention of the preeclampsia and its complication. Labetalol, hydralazine, and nifedipine, they are commonly used antihypertensive agents for the hypertension in the pregnancy. ACE inhibitors and the angiotensin receptor blockers, they are contraindicated as they affect the fetal development, especially their kidneys. The goal of the treatment of the severe hypertension in the pregnancy is to prevent the cardiovascular, kidney, and the cerebrovascular complications. The target blood pressure, there has been proposed to be 140 to 160 millimeter of the systolic and 90 to 105 millimeter of diastolic, although values are variable. The prevention of the preeclampsia, the interpartum postpartum administration of the magnesium sulfate is recommended in the severe preeclampsia for a prevention of the eclampsia. Further, magnesium sulfate is recommended for the treatment of the eclampsia over other anticonvulsants. Magnesium sulfate acts by the interacting with the NMDA receptors. Now the next topic is AED. AED is the automated external defibrillator. An automated external defibrillator is a portable electronic device that automatically diagnoses the life-threatening cardiac arrhythmias of the ventral fibrillation and the pulseless ventricular tachycardia, and it is able to treat them through the defibrillation, the application of the electricity which stops an arrhythmia, although the heart allowing the heart to reestablish an effective rhythm. With the simple ratio and the visual commands, AED are diagnosed to be the simple to use for the layperson, and the use of the AED is taught in much the first aid certified first responders and the basic life sports level cardiopulmonary resuscitation classes. Now the next is the malaria. It is also very important. The malaria, the clinical feature includes the fever, chills, rigors, and the body aches every 2 or 3 days. The labs includes the blood complications and the smear for the malarial parasite. Anti-malarial drugs includes the chloroquine, the tablet Naviquin P or the tablet Resochain, 250 mg 4 tablets stat, 1000 mg stat, 2 tablets after 6 hours, 500 mg and 1 tablet BD for 2 days. Injection chloroquine 200 mg per 5 ml. There is a Premiquin 15 mg per kg OD for 14 days, and the Amodiquin, Amiquin or the Bezoquin 150 mg, same dose like the chloroquine, such that the 1000 milligram stat, and then 500 mg after 6 hours, and then 250 mg BD for 2 days, and 10 mg per kg stat, and then 5 mg kg after 6 hours, and then OD for 2 days. And then the next is artemeter. It includes the capsule Artem, which is 40 mg 4 capsule stats, and the 2 capsules OD and for the 4 days, and the injection Artem 80 mg 2 injection stat in the gluteal area, then the 1 daily for 4 days. Artem Plus and the Lumefantrine, it is a tablet Gen M, which is 20 by 120 and 40 by 240 and 80 by 480 for the outdoor patient, 10 to 14 kg For 10 to 14 kg, it is 1020 by 121 WBD for 3 days. Then 14 to 24 kg, 45 to 41 BD for 3 days. And for 24 to 35 kg, 40 by 240 1.5 tablet BD for 3 days. And if it is 35 kg, more than 35 kg, then it is 80 by 480 1 tablet BD for 3 days. Then the injection Gen M, which is 30 60 120 mg adult. For the admitted patient, dose is 2.4 mg per kg at the 0 12 and 24 hours. And the preparation includes the injection Gen M 120 plus 2 cc NHCO3 and 10 cc distilled water IV slowly and into stat, then after 12 hours and 24 hours. The important is that if the patient is the Bivax or the OVAL positive, then give the tablet of Primaquine 2 tablet a day for the 10 days. Antimalarial in the pregnancy in all the trimester, the first line is the chloroquine plus the quinine, second line is the artemether or the artesunate, and second third trimester with the cautions and the pyrimethamine and the plus the sulfadoxine and the mefloquine. Contraindicated primaquine, tetracycline, doxycycline and the halofentane. Now the next topic is the breastfeeding as a contraception. The breastfeeding naturally suppresses the hormones that are necessary for the ovulation, release of an egg from the ovary. In the turn, they prevent the conceptions, and the baby continues the sucking. They can stimulate the hormones that suppresses the process of the ovulation. If there is no egg production in the body, then there is no pregnancy. Hence, the breastfeeding is a good form of the birth control, and regularly and the frequent breastfeeding as a natural method of the contraception. It is termed the lactational amenorrhea method. LM is effective, such that 98% effective women follows or meet the following criteria. The baby, they must be at least 6 months old, less than 6 months old, and they must exclusively breastfeed the baby during the day and the night, and must not have the periods, and they should not be top feeding or the extra bottle feed for the baby. For the most whom the breastfeeding is not a proper contraception method, when the baby she or he turns 6, and the breastfeeding is not an ideal position to prevent the pregnancy. And after they also keep in mind the LM, they cannot be used when you have taking the antidepressants, and the antidepressants, they make your baby feel drowsy and sleepy, which does not allow you to feed often, and this reduces the effectiveness of the breastfeeding as a form of the birth control. Doctor can help to suggest you to alternative method to make the breastfeeding effective as a contraceptive method. If the baby, they stop the breastfeeding and they started taking the solid foods and also with the breast milk, the lamb is no longer effective even if the periods still haven't returned, and one could be fertile and can get the pregnant again. The benefits of the using the breastfeeding as a birth control. The benefits for the mother, she does not need she does not affect the woman's natural hormonal balance, and that is safe, simple and convenient, and that requires no medical supervision. The prescription and requires the bleeding after reduces the bleeding after the delivery and prevents the pregnancy naturally after the delivery, and its effectiveness lasts up to the 6 months. The benefits for the baby, they provides the best nutrition and improves the bonding between the mother and the child, and the baby feels safe and secure around the arms while the breastfeeding. Antibodies from the breast milk, they protect the baby from the developing of the allergies and the certain infections, and they decreases the potential risk of any infection from the other foods. And the woman, they can start the breastfeeding shortly after the delivery, delivering a baby. If there is an issue with the breastfeeding, they seek the immediate help from a midwife or the lactation expert, so the lactation is not sporadic or the disturbed. It is always highly recommended to discuss with the doctor before you consider the breastfeeding as a form of the birth control. A doctor can suggest you some tips to make the breastfeeding effective as the birth control. The contraceptive effects of the breastfeeding, it is the lactation. The productions of the breastfeeding is controlled primarily by the two hormones, the prolactin and the oxytocin. The prolactin stimulates the milk production, while the oxytocin is responsible for the transporting the milk into the ducts and which connect to the nipple. Prolactin increases throughout the pregnancy, causing the breast to enlarge, and while a woman, they remains pregnant, she does not produce the milk. This is because the levels of another hormone, progesterone, also rises during the pregnancy. Progesterone is produced by the placenta, and so during the pregnancy, when the placenta remains in the woman, the breast milk is not produced. Following childbirth, when the placenta is expelled, the progesterone levels decreases and the milk production is stimulated. The infant suckling at the mother's nipples also stimulates the productions of the breast milk. The infant suckling continues to regulate the amount of the milk produces because the suckling action stimulates the productions of the prolactin, which is in turn stimulates the milk productions, and the amount of the milk produced by the lactation woman is equal to the amount consumed by the infant. When an infant stops suckling, the breast milk production is quickly cease. When an infant is suckling frequently and heavily, prolactin levels they will increase so that the more milk can be produced. So this is it. The lectures will be continued. Till that time, take care. Bye bye. Like and subscribe my channel. Thank you so much.